thank you for inviting me to speak to you about my research. And as Sue said, this is ongoing research, so very much kind of in its ever-growing, changing phases at the moment. And I am taking a human factors lens to an exploration of how midwives and maternity support workers who are on training programs work together and experience their work together. So I'll pull these themes around power hierarchy and staff safety through, and Helen and I very serendipitously, if that's the right word, met next to each other at one of the Midwifery Maternity Festival conferences, and beautifully found that our work links very much so. So we'll make some links between those two. Okay, so if I just tell you about my interest, my research at the moment. So we know that lots of different factors within the literature show us impact upon the ways that people in the workforce work together. We also know that lots of different factors affect the quality and safety of the care that we provide. And it's very difficult for us to pin down that one thing causes one effect, which is where human factors can help us to grow in our understanding. In terms of my project, we know a lot, or there is a lot of research in secondary care and in interdisciplinary collaboration. So the ways in which doctors and nurses work together, for example, in tertiary units. We really don't know a lot about how our maternity disciplines work together within their discipline. So how midwives particularly collaborate with support workers, essentially maternity support workers. We don't know a lot about UK settings, certainly within the literature. And I'll bring your attention to a couple of pieces that do tell us a little. But what I am proposing through my research is that we need to upskill this body of the workforce. We know that maternity needs are increasing. We know that our workforce strategies need to grow and enhance with that. And as our profession as midwives moves forward, we need to ensure that the service we provide is safe. And that the understanding of how we work together in these professions, of lots of different contextual factors that affect interdisciplinary working. If we understand those better, we can design systems in a safer, more effective and efficient way. So that is the aim of my projects. Very quickly, because I'm aware this is the fastest hour, a very quick introduction, because I'm very passionate, as I know Helen is as well. Human factors is a very commonly misunderstood and misinterpreted field. We often interpret it as factors of the human, and whilst that is part of human factors itself is the scientific discipline. So it applies theories, principles, data to the design, and it is focused very much, it's a design principle on the design of systems. It has two joint aims, and that is to optimize human well-being and system performance. Safety science tells us these two things are intrinsically interlinked. So our staff safety impacts upon our patient safety, and the reverse is true also. Our aim within human factors and ergonomics as a design principle is to improve the fit between people and their working environment. So whilst we might do interdisciplinary training, we might do training around communication, for example, these are all parts of it, but human factors itself is around improving the fit by design. And systems thinking is part of human factors. This forms the lens of the research that I am hoping to, or performing. So the way in which we think in a systems view is very holistic. We see the system as a whole. We're moving away from linear thinking, away from root cause analysis, away from sort of simple cause and effect, and seeing the systems as a whole. It is a holistic viewpoint. It's a way of, it's a worldview, essentially. It is non-linear. We consider the ripple effects. If something is happening over here, if we make a change in the wider parts of the system, how does that filter down? And I'll show you some models in just a moment. And what we know is that healthcare is the most complex socio-technical system in existence. And what I mean by socio-technical is that humans interact with technologies. And with so many interactions, so many moving parts, more so than in manufacturing, engineering, even in rail and aviation, with all of those different interactions between the parts of the system, outcomes are very, very difficult to predict. But safety science tells us that safety is a factor that emerges from the ways in which those interactions occur in a system. So essentially, if you boil all the parts up and all those chemical reactions occur, safety is something that is a product of the way that a system develops. so is a risk, so is resilience. All of these things are system properties. I want to show you these because I think it links with our power hierarchy and staff safety. These are two human factors models. The one on the left of the screen forms the lens for me for my research. I'll tell you a little bit more in a moment. The one on the right is a systems engineering initiative for patient safety. And on the right-hand side, you'll see it examines the system, the processes within the system, and we see those joint outcomes just where the big red arrow is that I've pointed on the screen. And I'm so sorry they're so small. But essentially, this recognises that patient outcomes and employee and organisational outcomes are intrinsically linked. They are both factors of how the system works together. We cannot see one without the other. We need to look at our staff safety in order to manage our patient safety. And methods, things like the SEEPS model helps us to do this. So this is the background to my study. I know the slides will be disseminated and I'm wary of time, so I'll just skim through this. I'm looking at the ways in which we train maternity support workers. So actually, we've not had maternity support workers in maternity services for a very long time, as they are now. It's from a 2004 report, where we started to integrate the role of the maternity support worker as opposed to the auxiliary nurse. It's quite a rapid development, really, of the role. And there's been a very, very limited learning offer to date. We see this rapid acceleration through 2016 and Better Birth, looking at the ways in which maternity support workers can help us to meet the aims of Better Birth's continuity, for example. And the Secretary of State for Health, which was Jeremy Hunt at the time, put forward an aim to professionalise the role of the MSW and to create an educational framework. We see that embodied in the workforce strategy. And as I said before, we don't have a lot of underpinning evidence to suggest to design these programmes based upon what we know about how these two parts of the workforce work together. But what we do know in the small amount of literature that there is, although it doesn't look small on this page, is that historically we have a lot of workforce tensions. There is issues around boundary keeping. Billy Hunter's work talks a lot around kind of the sociology and things around the ways in which we practice as midwives. There are themes around trust, respect, accountability. Our pins are accountability in terms of our professional, the ways in which we delegate tasks, for example, who retains accountability. But we do know within the literature that MSWs are deemed a positive and highly motivated group, but we do see issues with boundaries and differences in the ways that those two parts of the professions work together. What I've got here is my the lens or the framework which has formed part of the narrative review that I've undertaken as part of my research. And here I've used the elements of the system to frame the elements of the research, and we can start to see the gaps actually here. We can see that there are gaps in how interdisciplinary working is explored in how we use tools, tasks and equipment, for example. And Helen's work beautifully starts to fill those gaps, but that's been a huge thing that's come from me. We also know that the roles of MSWs hugely involve using tasks, tools and equipment and feeding those back through communication, accountability, delegation, back to maternity support workers. And again, I come back to, if we investigate this further, we can design these systems better. These are some key themes that have come through for me looking at the literature. There are not many pieces of empirical literature, but there is a big scoping review done by Griffin et al. And also a Swedish study that examined intraprofessional working on a delivery unit. And there are some quotes here that I've pulled. We see issues around workforce design. I don't think that will come as a surprise to anybody. But we see here workload pressures mean that development's very frequently reactive. Human factors can help us here. Design principles can help us here. We definitely see this variation in the learning offer, and I'm hoping that through the research that I and my university will perform, that we'll start to understand how these have been implemented. But we see a real want and need from maternity support workers to access educational opportunities. We do see issues around intraprofessional relationships. We see a few quotes on the page there, just on the second column. There's a nervousness about giving support workers greater autonomy. We don't know why in the literature as yet. There's a sense here they almost have to prove themselves. And if we consider the impact of that upon the individual, how the safety of that individual is affected, and thus the safety of the service that they are able to give. We see quotes around no one has the conviction to make the role work. There is a lack of groupthink, thinking outside of the box, and that the service doesn't always see the maternity support worker as a valuable asset. And thus the role is not always valued either. However, we see theme coming through around lack of understanding of what the role is and what maternity support workers do. And so there's a gap here between an assumption and an understanding that we can start to work within. But this gap, this boundary, has implications for staff safety and thus patient safety. And there are issues coming through the literature around role boundaries, essentially, that are very similar to historical work that has been done. So we can see some concern around roles losing midwifery posts. Midwifery is a veiled profession, so others seeing it through a veil that filters certain elements of practice. And you can see in the quote just at the bottom, if we perceive, or if individuals perceive midwifery through a veil that only permits certain images through, that evokes feelings of exclusion, frustration, and loss of control. Social exclusion and loss of control are perceived by our brains in the same way as pain. And so we can see there staff safety is hugely impacted by these experiences. It is most important that we look at the ways in which we cross these system boundaries. The gaps between professions give us a huge opportunity to improve staff and patient safety. And the bits upon this screen that will be disseminated are an example from the Stafford report, where there was very much a gap in the system boundary communication across them. And it matters because if we design work systems intelligently, we can help to manage issues such as power, hierarchy, and incivility. Incivility in the literature is a huge patient safety issue as well as a staff safety issue. We see incidences, particularly in operating theatres, and patient outcomes very negatively affected by incivility. And there's a fabulous website, Sue, that maybe we can disseminate called Civility Saves Lives, which has really brilliant links to literature available on the importance of civility within the system. If we start to look at linear thinking, root cause analysis, for example, we lose sight of things like civility, and yet they have massively intrinsic properties in terms of system safety. This is my final slide before I pass you over to Helen. We know that we have issues in staffing. We know that we have issues in our workforce. These have been magnified through the pandemic. And we know that our future workforce looks a little bleak at the moment, although I'm ever hopeful that we can overcome these issues. We have an issue around how we see resilience, for me, and this comes through in the literature, hugely in the literature. There is a rhetoric that's fueled, I feel, by individual resilience training. Resilience is a system property. It emerges as a result of different interactions within the system. When we treat error issues, harm issues, staff resilient issues individually, we're missing the ways that we can design the system to be resilient in itself, to remove those barriers that cause stress, that cause harm to staff. If we remove those barriers by design, we start to see, as the quote says at the bottom, we start to see resilience as a quality and safety issue, as opposed to an issue of individual coping, essentially. That is a much safer system to work in for staff, and ultimately connected outcomes for patients. I'm going to leave you with this slide. This is a safety culture discussion card that again, is disseminated through the links. These are a set of safety culture cards that have been developed by Professor Paul Barry and his team in NHS Scotland. They are free to access, and they are methods of opening safety culture conversations in your organisations. They are available and free to use on the link on the screen there. They are questions that we can ask of our teams, of our management structures, of each other, of ourselves, and they're ways to support systems thinking. And just linking in with my research here, we can feel these tensions, we can feel these barriers, notice them. They are quality and safety issues. Use the crux here as a questioning tool to see if we ourselves can better our systems. I'm going to just skip over that because essentially we are all part of the system. If we change our mindset, we hold our own individual accountability. We cannot hold the weight of the system. That is very important. But we can do our little tiny bit, even if it's just in the way we speak to somebody else. Consider ourselves as stakeholders and how we can impact design. Consider all of the elements, interactions of what is happening. Is something we feel today happening somewhere over there in the system? Often, the person who notices a problem is the best person to fix it. There are lots of opportunities that come about by distributed leadership, and also by seeing the system around us in a non-linear way, how we can design things better, even if it's in a system where one person is talking to another. Improve our communication, open discussions around things that could be better, and build our safety and learning cultures are the very clear themes that come through just at this early stage of my research. And that is me.